Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series that seeks to demystify mental health treatment. Today, I'm honored to welcome Dr. Gary Sachs, who is Clinical Vice President at Signant Health and the founder of Massachusetts General Hospital's Bipolar Clinic and Research Program. Dr. Sachs is an Associate Clinical Professor in Psychiatry at Harvard Medical School and was the Principal Investigator of the National Institute of Mental Health's Systematic Treatment Enhancement Program for Bipolar Disorder. Dr. Sachs is a Distinguished Fellow of the American Psychiatric Association and chairs the Scientific Advisory Committee of the Depression and Bipolar Support Alliance. Dr. Sachs has authored over 200 peer-reviewed articles and is a contributor to the seminal book, Managing Bipolar Disorder, a cognitive behavioral treatment program therapist guide, Treatments That Work, which addresses the management of bipolar disorder. Dr. Sachs, welcome to The Therapy Show.
My pleasure. Thanks for having me.
Can you start by telling us a little bit about your personal background and professional development that led to your research in the field of bipolar disorder?
I'll tell you perhaps two key events in my life. One really happened when I was a sophomore in high school. I grew up in Baltimore, and a young classmate asked me if I was interested in joining her in a volunteer program at the state mental hospital at Springfield State outside of Baltimore. And I remember the first day we went there, and it was actually quite terrifying to walk through the cottages that housed severely ill patients, many of whom had been there for many years. And when I came to the place where I was assigned, the nurse's station, I was surprised. The staff was actually very excited and talking enthusiastically about a new drug that was going to be available soon. That drug turned out to be lithium. And within a few weeks, I was there to witness some of those very frightening patients get better and get discharged. That was an extraordinary thing to see, and it has stuck with me ever since. And the next event comes some years later. I had already gone to college and to medical school. I'm doing my residency, and I volunteer on a first formal research project in medical school. I was involved in this study that was led by a professor who was really interested in diabetes, and he had recruited the most brittle adolescent inner city diabetics he could find, and he trained them to be counselors for younger diabetics. And the interesting thing about this project was, as these counselors gave advice to their charges, to the even younger kids, the emergency room visits for the counselors dropped. And that was really the idea of the research in the first place. It wasn't known to the subjects that the counselors were the subject of it. It was something that had a dramatic benefit to them. And I think that kind of improvement is in a way similar to what we see in self-help groups, peer counseling, as you might see under the auspices of the Depression and Bipolar Support Alliance, for instance. And it's interesting that if you allow somebody to make the transition from being the person getting the help to giving the help, it has a profound therapeutic benefit for everybody involved. So those have been really key aspects of early experience that influenced me.
That's very interesting. How would you briefly explain bipolar disorder to a non-professional?
This is a condition that was plagued by vocabulary problems. Bipolar is a condition that was conceptualized originally by Emil Kraepelin at the end of the 19th century. And what Dr. Kraepelin noticed is that some patients who had gotten ill relatively early in their life, as opposed to people who had been well and only come to the hospital, let's say in their 50s, 60s, or 70s, those people who had gotten ill early and had prominent mood symptoms tended to have periods of full recovery. He coined the term manic depressive based on that observation. And while he knew that some patients had only highs and others had lows only, he saw all of the patients who had that set of characteristics, early age of onset, periods of prominent mood symptoms, and full recovery, and put them under this one banner. Now, we have teased that apart and lost some of the simplicity and elegance of it, but what we now call bipolar requires that you've had at least one period of abnormal mood elevation. So that can be a manic or hypomanic kind of episode. And as long as you've had one of those, you will end up being called bipolar. And that's because our diagnostic system, the Diagnostic and Statistical Manual, or DSM, that we use, is focused entirely on sort of cross-sectional symptoms. So those prominent mood symptoms that Kreplin may have seen at some time in his charges, they're not always there. This is an episodic disorder, and it follows an irregular course. And we don't really know if somebody who's had a depressive episode will go on to have a hypomanic or manic episode. But once they do, we refer to that as bipolar disorder. People who have only had depressions have major depressive disorder. So we have an irregular course of abnormal mood states alternating with periods of full and sometimes near full or partial recovery. That's what characterizes bipolar disorder. And it's a very complicated thing to talk about because we've defined it based on those episodes of abnormal mood states. But in reality, if you were to interview 100 consecutive patients with bipolar disorder, you would be hard-pressed to find any of them who have only abnormal mood states. In fact, nearly every one of them will have one or more of some common co-occurring conditions. Those tend to be anxiety disorders, things like ADHD, substance misuse. There are a lot of those kinds of conditions that go along with bipolar, but also some medical conditions. It's very common that patients have migraine headaches or cardiovascular problems or respiratory problems. Autoimmune conditions are more common in people who have bipolar disorder, kidney problems. So we don't really understand what's behind bipolar disorder, but we do know that it's common, it's complex, it can be deadly.
And it's 7 days of a mania for a bipolar and 4 days of a hypomania for bipolar 2 with the depressive episode. Is that correct?
You have just hit on to something that I think is often not a very helpful distinction. But you're absolutely right. A manic episode requires that somebody have the abnormal mood state persist for 7 days rather than just 4. And to be classified as bipolar 2, you must have also had a depressive episode. In fact, by the time somebody comes to an evaluation, the difference between 4 days and 7, it almost never is helpful. Plus, you don't know what's going to happen in the future. The real difference between hypomania and mania that is useful is hypomanic episodes can have really intense symptoms, but they do not cause serious impairment in social or academic kind of function. So when you think about it, by the time you see somebody, they could be really, really jovial, talking a mile a minute. But if this person is still able to carry out their function, then that's a very useful kind of distinction. Whereas the person who has lost control of it and their episode is so intense that it causes that kind of impairment. And I should say, by definition, if the symptoms of mood elevation have resulted in hospitalization or psychotic features are present, things like hallucinations or delusions, that by definition is mania, even if it were quite brief. So we don't necessarily require that psychosis be present all the time to say, oh, this was manic. But if somebody at some phase was having auditory hallucinations while they were feeling euphoric, they're going to be diagnosed with mania. In the Kreplinian conceptualization, Bridget, we're talking about something that included longitudinal dimensions. So understanding age of onset, the course of illness, so full recovery. Those turn out to be dimensions that are delivering much higher levels of diagnostic confidence than 4 days versus 7, or was this irritability? Was this person talking too much? Were they having racing thoughts? The cross-sectional symptoms are, by DSM, the defining characteristics of episodes. And episodes are the building blocks for these lifetime mood disorder diagnoses. But it turns out that they're actually not very reliable. And things like impairment is more reliable than most cross-sectional symptoms. But it turns out that age of onset, course of illness, response to treatment, and family history When you put those together with the cross-sectional symptoms, now you're able to have much greater confidence in the diagnosis. We have actually developed some ways to quantify each of those 5 illness dimensions against what is the classical conception of Kreplin's manic depressive illness. And that has turned out to be useful both clinically and in research because it gives us a much more reliable diagnosis than the DSM can give us.
Thank you for clarifying that. Can you talk about your current research in the field of bipolar disorder?
There are a number of different things that I do, and I have to say this has been an extraordinarily rewarding kind of career to have. Since I get to work on studies that introduce new treatments, I've been involved in the development of drugs like lurasidone and more recently lumateperone that appear to be excellent treatments. They've had positive trials for acute bipolar depression, for instance, and that's really encouraging. So getting better treatments to patients is extremely gratifying. I've also been involved in trying to understand the nature of placebo response. And this is a mysterious idea that we could give somebody a physiologically inactive treatment and have their condition improve. That's not just measurement error or being mistaken about the diagnosis in the first place. It's actually using the patient's capacity for healing that changes brain function in a way that is similar to the kinds of medication and psychotherapy treatments that we give, but it is initiated within the patient. I believe understanding that as part of a self-management strategy and trying to harness it better will be one of those areas that in the future gives us a much better handle on how to manage this condition than what we currently are doing.
I noticed you're interested in patient-centric outcome measures. What does that mean?
This is a term that is also kind of abused. People will declare that they're very patient-centric. They mean by that is that they have thought about what they want a patient to do. In my work with the Depression Bipolar Support Alliance, I've really come to appreciate the gap between what we as clinicians and even regulatory authorities deliver and what is meaningful and important to patients. So, for instance, kinds of studies that I mentioned for acute bipolar depression, they're approved by regulators based on, let's say, change from baseline scores on a rating scale at week 6 or week 8. In STEP BD, we used a different kind of outcome measure, which was durable remission, meaning 8 consecutive weeks well. And I can tell you, when we spoke with patient groups about that, they considered having a sustained remission of 8 weeks to be far too short to talk about. And of course, that's correct, but no study has even used that other than STEP BD. Drug development, as I said, is based on change at a given defined 1-week time. This is not what is important to our patients. They want to thrive. They really want their full function returned in life. And if you say, well, we'd love to do that, let's see if we can get you better, they don't mean, oh, you'll be 25% or 50% or 70% better at 1 week. They want to know, what is the chance that if I take this treatment, I will have a meaningful recovery? And patient centricity then is a concept that's not all or none. You would certainly imagine that there is a certain amount of patient centricity to saying we have a higher percentage of patients who have improvement at week 6. But you'd probably also agree that there's a lot more patient centricity to say, here's the percentage of patients who had recoveries that last 6 months or 6 years. That kind of thing is really important. Patients also want to have their perspective incorporated into some of the design of studies. And for instance, in a way that I hope doesn't seem either mundane or unobtainable, we bring patients into research studies and we give them an evaluation that is often much better than they will get anywhere else. These are extended, careful clinical and laboratory assessments. Then we give them something extremely valuable, which is a course of treatment under double-blind conditions. And that's something that when you have the outcome, that is the pure gold. But unfortunately, then we say, thank you very much, and they go home and they don't get to take those assessment outcomes or the benefit of the treatments with them to their next care provider. We ought to be able to make the research experience more patient-centric by letting patients know what we found both in their assessment and over the course of that double-blind treatment. That would be truly patient-centric from my point of view.
And given the complexity you described and the importance of assessment to the treatment process, how do you approach treatment for bipolar disorder?
The thing that is really important is to realize that treatment is complicated and we have to make some distinctions about our approach right from the beginning. So under conditions that we might call urgent, the urgent care approach when somebody's life is at immediate risk, for instance, that focuses on delivering treatment that is as effective as possible, as quickly as possible, in the hope of saving the patient's life now. And that is driven by the clinician's responsibility. And I take responsibility for that when urgent conditions are in evidence. So if I think the patient's life is at imminent risk, I have to intercede. And it's not the time for a long, detailed discussion. However, those instances are actually very rare, probably a fraction of 1% of the time in my experience. More often, we're practicing under conditions that we would refer to as sequential care. And in sequential care, what we're doing is beginning with a discussion of what the patient's conceptualization of their problem is. What is it that they want treatment for? And there's no requirement that they say bipolar disorder or any term that I might find in the DSM. They could call their condition peanut butter if they liked. But once we agree what their goal is, then we can begin to agree about some measures to see if they're making progress toward that goal. So that kind of concordance about the purpose and an agreement to measure the results and have some guidance, that kind of approach is appropriate for the vast majority of patients. The problem with it is that getting measure-based guidance for most patients is not something that can be done within the time limits of the usual clinical appointment that they have. So we have found ways to automate the assessment process, move that outside and complete a pre-assessment and get that measure-based guidance from formal scales into the discussion between the patient and the doctor without taking time away from the rest of their interaction. That is a key thing because it allows you to practice this very, very simple process of keeping the things that are working and getting rid of anything that isn't working or isn't tolerable. When you do that, you're driven by having one of those definitive outcomes. It either worked, it didn't work, or you couldn't stand it. If I do that, if I obtain that kind of outcome in each and every treatment that I give to a patient, we can begin with a discussion of what the reasonable options are and try them and be guided by the results so that we can update this menu of reasonable choices based on prospective kinds of outcomes rather than what we have when we start. We have to look at the patient, understand what might be evidence-based treatment for their current state. And that's all based on somebody else. And it's a great starting point, but we don't want that to be the only kind of guidance we get. We want personalized kind of guidance from these prospective outcomes. And that's our collaborative care kind of approach to treatment.
So it sounds like technology can play a role in the assessment and treatment of bipolar disorder.
It really can, and I don't want to overstate the case of it because I hope in my description what came through is that technology is in the service of a therapeutic alliance, not a replacement for it. I think it's amazing we haven't really had consciousness of what we're doing in the clinical space as we keep having more and more apps and internet-driven therapies. The idea of replacing that therapeutic interaction with anything electronic, if that was going to work, Some years ago, we started to have many more apps than we have clinicians in this country who are doing psychiatry. And it seems to me that there's a role for that when it serves the therapeutic alliance, but people are not looking to have internet-based cognitive behavior therapy. They are best served by having that same kind of therapy, if at all possible, in the context of a real human-to-human interaction. Now, having said that, I'm more than happy for that to be over a secure internet kind of connection as we use things like Zoom or GoToMeeting. That's fine, but to think that we're going to have people talking to bots, I'm not sure that that's really going to be a good use of technology.
Since bipolar disorders may include manic, hypomanic, and depressed mood as a potential symptom, what are some of the issues that may occur with medication management?
When we think about those acute episodes, hypomania, mania, we think of as seeing the world kind of through rose-colored glasses and maybe depression as quite the opposite. And that idea shows you where the challenges are. If I was treating somebody's arthritis, their entire perception of themselves is not altered by the current state of their joints. However, when you're really depressed and you can't see anything positive, that makes it really difficult for you to participate in the evaluation by yourself, the decision-making by yourself. So calling the shots by yourself is really difficult the more severe the mood state is, and especially if you're manic and through those rose-colored glasses, you don't see any problems and you're not worried about risks. Those are severe obstacles for treatment to overcome, and it's best overcome by having, I think, a collaborative care plan that includes what we refer to as a care partner, somebody who you can trust and loves you, who can be available to help you make some of the critical decisions that need to be made when you're not so well.
Why is early intervention important when treating people with bipolar disorder?
I'll tell you my experience with this. It's interesting. We have, over the decades, had lots of people who have really gotten better and plenty of them who have not, Bridget. But when we try our best and somebody doesn't get better, there's not a whole lot that I can say about that. But one of the really sad experience is having somebody find the right treatment at age 32 or 42 who had begun to get ill, let's say at age 22 or 18. You don't get those adolescent and early adult years back. Those are times that are critical for attaining adult developmental milestones, finishing your education, forming intimate relationships, getting your career started. That decade between 20 and 30, when you lose it, that's terrible. And as I said, if it can't be helped, if you turn out to be one of those few patients who we don't find a good treatment for, it's certainly sad, but it's devastating to have somebody have a great response at 32 or 35 who has lost that critical decade because you don't get that time back. Now, can we say that everybody benefits from early treatment? I think that might be a stretch, but if you don't try, you will never know. So the earlier you're treated, especially if you're successful, we're talking about, at worst, having either fewer, briefer, or milder episodes. And you think of the cumulative advantage of that. The further you get with meeting those milestones, you've completed your education, you've formed a relationship, you've gotten your family started, your career started. The later you are into that process, before you have a really debilitating condition, the better off you are, and the more chance there is that you will entirely avoid that kind of bad outcome.
Why is it important for clinicians treating patients to be trained in the most up-to-date treatments for bipolar disorder?
I guess the problem I have with the question is the most up-to-date. I'm less concerned that a clinician knows what was approved last week or last month than that they simply distinguish between evidence-based treatments and those that are not. And I think we have a duty to all of our patients and their families to make a clear distinction between so-called proven treatments, if If we're talking FDA approval, that's a pretty exclusive club. We might add to that other agents that might have had success in double-blind controlled trials with adequate samples. When you start looking at those kinds of treatments, if somebody has recommended something else and you get better, I guess that's fine. But if they have recommended something else and something else, let's say omega-3 fatty acids and low oxidative stress diet and gluten-free, all the different things that might be fashionable at some point, but they haven't recommended the treatments that are proven to work for the condition you have, that to me is really inexcusable. It's easy to know the members of that club for each of the bipolar indications: acute bipolar depression, acute mania, preventing recurrence. There are some agents that have been shown to work for patients who have mixed features, and those should always be offered first. I don't think patients are under any obligation to accept them, but I do feel an obligation to always inform and offer those choices first. And then if we want to get into some of the more novel things that somebody somewhere has said helped one person or another, that's fine. But I do think we have a standard here of offering proven treatments first that is really important.
If a person is diagnosed with bipolar disorder, what are some of the risks they may face if they do not receive effective treatment?
Not attaining those developmental milestones that we talked to. That sounds bad enough in the abstract. In reality, these are heartbreaking things to see, that somebody who is in the office acutely manic, who may not accept treatment, and maybe their family or the friend who came with them said, oh, no, he's always like this. They go out, and those are people who end up doing things that can, in short order, ruin their lives. Now, does that happen every day or every week? No, but it happens often enough that you realize these are actually very high-risk situations, and not just from things like suicide, but from ending marriages and losing jobs and friends. Those are extremely costly events that are hard to undo once they've happened. I think it's also interesting how much easier it is for patients to be forgiven for any kind of manifestation of depression. But for mania, it really isn't. And even the kind of joke that you told when you were hypermanic at the company Christmas party can alter your career. So those are things that really make it problematic for somebody to decide that, oh, they really don't need treatment. I would much rather have them decide, let me try treatment for a year and see if I'm better. Let's see if this idea of measure-based guidance can actually produce a result for whatever it is that is meaningful to that patient. And giving yourself a chance to evaluate treatment, I think that is absolutely the best approach.
What are some of the reasons someone would refuse treatment?
There are a couple things. I think first and foremost is not agreeing with the diagnosis. So if you don't think you have the condition, why in the world would you want to be treated? But if the people who know you and love you think so, it can be very worthwhile to say, okay, I don't think I have this problem, but I'll take this treatment and we'll see. We'll have a measure. And in a couple of months' time, if you have a definitive outcome, that's terrific. The other things, we are duty-bound to describe the risks and benefits. And when you start talking about risks, it's really hard to do that in a measured way that would make the treatment sound at all attractive. Every treatment I know of for bipolar disorder has a black box warning that I have to discuss with the patient and their family. And they can really be off-putting. Yet those are rare conditions, mostly ones that we can monitor for and adjust. And I would like everybody for themselves to be able to evaluate that risk to benefit ratio, or benefit to burden ratio, if you will. Any treatment that doesn't give you a benefit isn't worth keeping. About it, right? You would put up with 0 side effects for a treatment that was doing nothing for you. But you should be able to decide for yourself what the trade-off is. If now you're doing a lot better, how much adverse effects would you be willing to bear in order to do that? Some people will be put off by things like weight gain. And if you think about it, if you had a treatment that really worked for you and caused you to gain, let's say 2 pounds a month, at the end of the year, you would be really concerned about that. And that might change your metabolic risk profile in a way that's medically really very important. However, we don't have that choice. We can look at the outcome, and if it looks like this is a beneficial treatment at the rate of gaining 2 pounds a month, we can add in a certain amount of, let's say, brisk walking that would balance out the increase in appetite, for instance, that might be part of taking the medication. We can institute diet plans. There are so many different things that we can do, but they're not up to me. They really are up to the person themselves to weigh. But how can you weigh that without knowing whether there's a benefit?
And do people enjoy their manic episodes or hypomanic episodes to the point where if you give them medication, they might miss feeling the elation or the mania?
I mean, that comes up. It's actually not something that is as common as you might think. And that's for a couple of reasons. One is that a lot of people will actually perform better when their thoughts aren't racing, when they're not so irritable and they're not manifesting grandiose behavior. Some people who are literal rock stars and they think they were much better when they were manic, but their bandmates will tell them otherwise. So there are times where you feel you're not as cognitively sharp. And remember, treatment's not all or none. So we can adjust the dose and see if the side effects can be more tolerable at a lower dose and still get the benefit. I think those are all things to be explored as opposed to predicted and excluded without a therapeutic trial. That measured outcome at an adequate dose is critical to making good treatment decisions and putting together a plan that can be life-changing.
You're talking about a really targeted, tailored approach to each individual patient.
I mean, that may sound tailored and may be difficult, but the principle of let's keep the things that work, get rid of the things that didn't or that you can't stand, that's the way forward. If we make those definitive treatments, we narrow down the menu of reasonable choices going forward, and we're keeping the winners and getting rid of the losers. That makes the process very personal, and it gets you to a good result as soon as I can get anybody there. Right now, I don't have any better way to match people to treatments.
And it goes back to your idea or your belief in that collaborative approach.
It's really important thinking about collaborative care that the collaboration is between the patient and the care providers and anybody else who becomes a formal care partner in the kinds of written collaborative care plans that we put together. Those are working arrangements where we're testing out not just medications, but other management strategies and trying to find ways to go ahead and attain those developmental goals, social, occupational, personal goals that patients have. That is a really fruitful kind of endeavor, whereas just imagining, oh, here's the recipe for your condition, just go and do this. We're seldom able to be successful trying to do it in one shot.
So is there anything else that I didn't ask you that you think it is important for people to know about?
There are so many aspects of this disorder. I think the main thing that always comes to my mind when I'm trying to think of what did we leave out of this discussion, and gets back to that idea of patient centricity. A lot of times what patients want comes down to being able to follow through on their plan. Just like most of us have had the experience of deciding we want to lose 10 pounds, so we go on a diet and then we don't follow it. This idea of making a plan and following through on it. What's interesting to me is that the success rate goes up when you have those care partners, when you're engaged in collaborative work, that doing it on your own is not nearly as likely to succeed as being engaged with other people who you have empowered, who you have told how you want to function and what to look out for. That kind of thing, I think, often gets left out of the discussion, that we're, as Americans, committed to this sort of rugged individualism, that we should all fix this on our own. And I think the sooner you get somebody involved as a care partner one way or another, the better off you are.
Dr. Sachs, what are you most excited about mental health treatment today?
I am really very interested in the peer support model. I am interested in seeing what we can take from placebo response, as I mentioned at the beginning, and start to bring that into self-management strategies. One of the ideas that I find really appealing, it's actually a Buddhist kind of idea, and it goes with the model of riding an elephant. And if you're sitting on the elephant as the rider, you could think about that as your rational mind. But when you start thinking that you're steering the elephant, you're usually fooling yourself. And so there are aspects of what happens to your brain when you're getting treatment, the things that relate to placebo response, that are more like training the elephant than they are like lecturing the rider. And those are the kinds of things that I'm very excited to learn more about that. I am certainly excited about the opportunities to bring in technologies that are in service of reducing isolation and a sense of purposelessness that patients often have that really are deleterious, and technology can help overcome them.
Any examples of that technology?
I think the COVID situation, if there's been a silver lining to it, it really has been that there's been a relaxed regulatory environment, so that right now, if you are in North Dakota and there's no provider, there's no provider. But under the COVID conditions, the CMS, the Medicare providers, they've said, okay, right now you can practice across state lines. Right now, you can, even within your state, you can have remote visits. So when you think about what the nature of bipolar disorder is and acute mania, and I'm going to say you have to drive into Mass General and see me in my office there, and you live even in a close by suburb, that's a very tall order, where we just take something like a Zoom meeting or go to meeting kind of conference call, and now I can interview the patient and their family members without the need for them to come into the hospital. That seems pretty simple, but I consider it to be a major advance, and I'm hopeful that change will be retained when the virus is no longer wreaking chaos in our society.
I agree with you. And if you had a magic wand and could improve one thing about mental health treatment today, what would it be?
The one change that we haven't talked about that I would love to see is that in our conversations about the conditions, the symptoms, that we start to find ways to have the conversations that are not pathologizing in and of themselves. This relates to stigma in a way, but there is a great tendency to see everything that happens to a patient as a manifestation of their illness. And if I had a magic wand, and in every time where that comes up, how would this be different if mental illness wasn't part of the discussion? And quite often we're talking about things that are well within the so-called normal range. And I think by depathologizing, we can focus on what's important when there really is pathology and not get sidetracked into debating things that truly are highly debatable and you're not on ground then. So we may as well move off of those things and try to be very careful to avoid making things illness when they're really just part of life.
I like the destigmatization of mental illness. That's very important. And also, I might be wrong, but I think that's what the DSM-5 was trying to do, was to make it more dimensional. Am I correct?
DSM-5 had some really wonderful, well, it had some really wonderful ambitions, but it fell short on almost all of them. So the benefit of DSM-4 over DSM-5, we probably could talk for a couple of hours about the very fine distinctions. I just think it was well-meaning, but it really didn't work out very well.
I thought that was what they were trying to do, was kind of make it more dimensional and less categorical.
There were efforts along those lines, and also to make it more based on biological markers. I said before, the dimensions of illness, the current signs and symptoms, age of onset, course of illness, response to treatment, family history. Those 5 dimensions are what are used to validate any psychiatric illness. And that Robbins and Gouset wrote about this, I think, in 1970. And we could change some of the terminology. Instead of family history, we could say biological markers and expand it a little bit. So DSM-5 thought there was going to be a lot of these biological markers that could validate the conditions and separate out these from each other and from what we might call the range of human suffering that is apart from illness. And it just turned out that we weren't ready to make that. Now there's something called the research diagnostic criteria, and there was something called the research diagnostic criteria, and there's so-called RDocs now that are trying to come back to that and get a circuit-based approach to classification. I don't know if that's going to work out so well either. One of the things from our research that is interesting, and that is as we look at people who enroll in trials and see whether there are higher confidence diagnosis versus less confidence diagnosis, people with less confident diagnosis don't do as well relative to placebo on active treatments. So the difference between active treatment and placebo is greater when you really do meet those criteria. So there is something in the DSM that probably is valid and meaningful. If you come close but not quite make it, that probably is something fundamentally different. And there are a lot of nuances to this to understand. But I think the bottom line is that there needs to be an improvement in the assessment techniques that we use and make it more reliable and higher confidence.
I agree. So Dr. Sachs, on behalf of myself, my listeners, and all of the people that you've helped through your work, I want to thank you for your contributions to mental health treatment and for taking the time out of your busy schedule to help me and my audience better understand the field of bipolar disorder.
Thank you very much, Bridget. I really appreciate the effort that you make to get these shows together and get the word out. Those are helping many more people than I can see in a week, so I thank you.
Thank you so much for that. Be sure to check out my website, therapyshow.com, which has many resources about mental health. There you will also find how to submit questions, stories, or insights that you have about the mental health system, or suggestions about who else I can interview and how I can improve the show. I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and people around the world can gain more benefit from therapy. There is no need to suffer in silence. Get the help that you need to create the life that you want.